Nursing Conference, High Tech and High Touch Revisited, New Perspectives on the Future of Nursing. This virtual conference is presented by the New York State HIMSS Chapter Nursing Committee to celebrate nurses during Nurse Week. I would like to thank our members, Dr. Mary Joy Dia, Dr. Jessica Varghese, Dr. Olga Kagan, Katherine Crookston, Dr. Kathleen Mcgraw, Licia McMyers, including Tony Ferrante, Nick Cristiano, and Sebastian Roy, who all work together to provide this conference for you. Alicia McMyers is our chat moderator who will field the questions that you send in for our speakers. I would now like to invite our producer, Sebastian Roy, to share a slide with directions on how to use Microsoft Teams and chat features during this conference. Sebastian?
Thank you, Eileen. Hi, everyone. My name is Sebastian Roy. I'm a treasurer here at the New York HIMSS chapter and also the producer of today's event. We're very excited to bring you this excellent presentation and panel discussion for you all today. I'll be going over some quick features of the Teams application before we get started. So you might notice the attendees that we cannot hear you or see you, but you are obviously able to hear and see us. You are able to ask us questions, though, using the Q&A function. You simply have to look for an icon on your screen that has a little question mark in it. And if you use that, you can ask us questions throughout the discussion today, and we will have someone monitoring those questions and feeding them to our moderators and panelists to inform the discussion. There is also closed captioning. If that would make your viewing today more easy, please feel free to use that. If you happen to be viewing this presentation in a web browser and you run into any kind of difficulty, such as the screen freezing, simply refresh the browser page and that should work. And a reminder that, like all our events, this event is recorded and the recording will be made available on our YouTube page within a few days, typically at most a week. And we also have encore presentations of this panel discussion at 2 times tomorrow as well. I also want to take this opportunity to encourage those of you who are not yet members of HIMSS to join our chapter. You can do so at hims.org. And if you choose New York State as your chapter, then we also get a part of your membership fee as a contribution to our funding, which helps us put on events like this event today. If you want to see our full calendar of events, you can use the QR code that's on the screen right now to go to that page on your phone, including our encore presentations tomorrow and upcoming presentation webinar on May 26th. And you can type in the link on the screen, which is is.gd/HIMSS, HIMSS. For now, I'll pass it over to our last-minute fill-in moderator for our first part, Olga Kagan, as Vaninma Lalsa is having technical difficulties joining us. So Olga, over to you.
Thank you, Sebastian, and thank you, Eileen. I'm happy to be your moderator today, and we have wonderful presenters. We'll start with Dr. Mary Joy Dia, and also with Dr. Jessica Varghese. I would like to now ask Mary Joy Dia to please introduce yourself and tell us a little bit about your topic. Thank you.
Thank you so much, Olga. I'm just going to share my screen. Hold on a second. And this topic is really close and personal for myself. I started this journey with these research collaborators, Dr. Deidre O'Flaherty, Tatiana Marie Arreglado, and Dr. Joyce Fitzpatrick, who has been our mentor way back when the typhoon hit New York, and that was Sandy. We were all together starting our DNP program, and we were involved with identifying a nursing concept that is relevant and meaningful for us. And having some of our classmates go through this turbulent event at that time, we thought that resilience will really apply to us, particularly that one of our research collaborator, Deidre, we were all working in a hospital, and her house was burned down, and still she continued to do what she needed to do. So it's also timely at this time that as we continue to reflect back on what happened during the pandemic, COVID-19 challenged nurses globally in multiple directions. We struggled and tried to hold fast and keep the course steady for everyone. And nurses in leadership roles had to prioritize the safety and containment of everyone while managing hospital operations. So a lot of healthcare organizations struggled with lack of personal protective equipment, bed management, and staffing due to the unprecedented surge of patients in the ED, and of course, the need for intensive care beds. So this is really our way of sharing our perspective and looking back from the Year of the Nurse on what happened, and proudly reflect at this time as we celebrate Nurses Week and honor those fallen heroes within our organization and also across the world. So my goal is really to compare and contrast concepts and research studies on resilience and how did our nurses respond during the COVID-19 pandemic. At the same time, we know that there were targeted interventions that nurses can benefit in terms of building our own team resilience in the workplace environment, because obviously we need to continue and support each other and explore those lived experience from our nurse leaders. So this way we can address what could happen potentially in the future. There are so many traumatic events that we deal daily from deaths of our patients, but at the same time, we're also affected by the political events that's happening across our nation. So our goal is really to focus on studies and interventions that can foster resilience and correlate this in our professional competencies. So I know that the world have called us superheroes, but even prior to the pandemic, we have seen how critical nurses' role as, and from the bedside itself, we are challenged in trying to retain and recruit our nurses who are constantly exposed to life-threatening situations such as trauma and death. We continue to find our nursing profession fulfilling those. So the trait that really comes out for majority of our nurses is resilience. And it is really the process of adapting well in the face of adversity, trauma, tragedy, or threats, or significant sources of stress, right? Because outside of work, we also need to deal with our own family and relationship problems, or even our own health problems and financial stressors. So it's really hard for people to bounce back from difficult experiences. But research has shown that resilience is ordinary, not extraordinary. People constantly demonstrate resilience. And we can see this even during the past year, even though we were all overwhelmed by what happened a year ago. We are still here trying to slowly reintegrate and adapt with this new, better normal as we keep on trying to reopen new spaces and socialize again. So research studies, and I think there's just a slowness on how I click my slide here. Research studies by Shakespeare, Finch, Gow, and Smith have described characteristics that support resilience in our workplace. And this includes extroversion, openness, being agreeable, being conscientious. And sometimes you also find humor trying to support us as we try to laugh about what's happening in our workplace. And also facing fears of our own mortality as we try to comfort a patient that probably has been diagnosed with cancer and still retain that positiveness, right, and optimism that things would go better. So the use of social support has been identified as important in the development of resilience. And I think we can all relate to this. Strategies that nurses utilize in terms of just supporting each other with just simply talking about what happened during the day. And of course, having the teamwork in just trying to reaching out and trying to see, is there anything I can help with you? So those are like daily things that we do. And the professional organizations such as the Association of Critical Care Nurses in 2015 have really endorsed the importance of nurturing a positive healthcare environment, while healthcare organizations offer mindfulness classes and health promoting activities to support employees in reducing stress. And it's so just coincidental that I was listening to the Future of Nursing Campaign 2020 to 2030 report, and one of the key takeaways that I have listened from that report is the recommendation number 3, which is really focusing on the well-being and health of our nurses and doing a resilience engineering. So one of the best practice recommendations is really working together with our nursing management and also with the leadership and educators in trying to facilitate resilience training in the workplace, such as mindfulness that can support our nurses in reducing stress and assist with their critical reflection on what happened during the day, what could I've done better. And the goal is really to promote a work-life balance and health promotion so we could build resolutions that could develop and strengthen our own personal resilience. Nursing educators can be instrumental in promoting this mentorship workshop so that we could continue our critical thinking and build our hardiness skills. So resilience can really encompass both for seasoned and novice nurses. We can address the real and perceived difficulties that we encounter at the workplace. And it really opens hope for nurses. So they could increase that resilience factor within themselves and still continue to find meaning with their personal and professional journey. And one of the things that nurses are really known for are being healers and caregivers. We have the skills to do our self-care by really communicating with our patients and also doing our own team huddles, right? We can incorporate these self-care concepts during the time. So one of the things that was facilitated during the pandemic is in DeGraff's workplace, they actually have called a special group called Team Lavender. And what the Team Lavender do is they did rounding and provide care packages to their staff. And they also offered food snacks and other things like essential oils. So this way, staff that are tired can really take a break and just smell the good essence of that oil, such as eucalyptus. They also have a pastoral department that rounded not only for the patients, but also to provide comfort and healing for staff that might have taken care of their colleagues who got sick of COVID-19. And I can remember clearly when we were trying to just talk to each other, and I used to work at another hospital, and knowing that another colleague of mine passed away, and even though I had not seen that person for so many years, it still affected me personally. So all those kind of support and just talking it out with each other really help. So the resilience training program really focuses on training nurses to help them assist with their peers. And this really also includes other self-care activities like mindfulness. So this is just like a picture that DeGraff have shared with us in terms of like how did they try to promote that sense of belongingness and support during that height of the pandemic. And of course, from the hospital management perspective, They made sure that staff are safe, that they're constantly informed of what's going on. And of course, they also focus on the patients in terms of like providing devices. So this way they could talk with the patients and really standardizing the equipment. So this way it would minimize the source of infection. And this really is like a way for them to just, show their togetherness and still be there for each other, and having this sort of like a banner saying "I love New York" really attests to the fact that despite of what's going on, they're there for the New Yorkers. And then from an education perspective, one of the things that our mentor have shared with us, Dr. Joyce Fitzpatrick, is that she noted that the nursing faculty and students have to really switch gears in providing support because of the increased need of nurses working at the bedside. So a lot of switching has to be done in terms of like going back to the clinical area. And it's important from the educator's perspective to prepare these nurses. So this way, they can be more familiar and confident in working in places that they have not done for so many years. For example, for myself, even though I work at the ICU, I am not so familiar anymore with the equipments and all that. So creating a team and nurses who can volunteer, but at the same time giving them the support is really important. And some of the things that they also facilitated is having these discussions with Jean Watson, who was a nurse theorist, and then having that conversation on giving sort of like an educational support for our members. At the same time, we know that there has been a need in trying to work quickly with our IT department. So our research collaborator, Tatiana, who played a role in addressing the COVID crisis at one of our Health and Hospital Corporation hospital, really was instrumental in providing a modified hybrid cross-discipline training. So this way, hard clinical staff could be trained quickly and also allow access to the different modules of the EMR. So this way, the user can then work quickly in adapting to the ED, inpatient or outpatient units. So, caring for the COVID patients is really time consuming with all the doffing and gowning that needs to happen. So they need to adjust in terms of like adjusting the documentation policies and updating it to this way it would reflect the disaster mode assessment. And somehow this kind of like alleviated the stress that the nursing staff have experienced. At the same time, need to consider the telehealth perspective of it and connecting patients with their loved ones and doing televisits. So nurses were really there in being that family for that patient, aside from the loneliness that the patient feels not having their family at the bedside. From a professional nursing organization, I wear the hat of being the president of the Philippine Nurses Association of America. And it was really heartbreaking during the height of the pandemic because our president got sick of COVID and ultimately her husband passed away. I have to step in temporarily as the president during that time. And what we did is create a COVID-19 task force and really understand what's going on across the United States, because we have 55 chapters in 43 states, and just trying to communicate and check in with our members what's going on. As you can see in the report, even though we comprise 4% of the workforce, Filipino-American nurses was disproportionately affected by the pandemic, with 30% of deaths affecting our community. And that was really heartbreaking for many of us. We launched the Healer Nurses campaign. Our priority was really providing masks for our nurses. So we provided cloth masks and delivered foods in hospitals that needing it. And at the same time, our retired nurses sewn cloth masks and delivered this to the hospital, including the homeless shelters. So really, to think about it now, even though that was a year ago, we know that the effects of COVID-19 is still with us from a psychological impact perspective. Some of the reports that we have heard from the ICN shows that 93% of nurses suffered from moral injury. So how can we really heal our nurses for the long haul? even though there's still some things that's going on in terms of promoting vaccine trust and confidence amongst our nurses. So the resources that we have really looked into is the stress management and resiliency training. We launched the emotions behind the mask survey, and it's interesting to show that even though nurses suffered a lot, the biggest worry in their mind is really keeping their family safe. And the top 3 coping mechanisms that they have adapted during the time is really staying socially connected, engaging in spiritual practices, and also outdoor physical activity. Within our organization, putting on my hat as the president of PNAA, we have launched the resilience training program. At the same time, some of our practice committee, led by Dr. Sherwin Imperio, have created a culturally congruent peer-to-peer support, which we call Kabalikat program, which means a body system, so to speak. And then I know that you're familiar with the wellness app that was developed by Charlene Clayton, and we're also trying to promote this within our organization. And of course, the mindfulness exercises. So in conclusion, nurses' perception of our own resilience really shows that a lot of us have moderate resilience score, and this is another study that we did. And really understanding social demographic factors such as age, gender, race, education, and area of practice can guide organizations in developing an individualized resilience building intervention that is appropriate, acceptable, and easily adaptable for new nurses and also for those in leadership position. Stressors can change one's ability to adapt despite our high resilience score. So it's important for us to continuously adapt these exercises, such as mindfulness, having our self-care, and having that break for ourselves. And I know that this is a good way for us to just reflect again and ask ourselves, how do we take care of ourselves during this time? So thank you so much for the opportunity, and I give it to Jessica, I think.
Thank you very much, Dr. Dia. And now I can say that Vaninma was able to overcome the technical difficulties. And Vaninma, if you want to take over, we appreciate it. Thank you.
Thank you. Thank you so much, Eileen, and thank you, Dr. Mary Joy Dia. That was very insightful. I am proud to be a part of the HIMSS mission, where we're driving nurturing compassionate care while driving technology, where we think the two can't coexist. In this group, we make it exist. And so I continue to be honored to introduce our additional members and speaker, Dr. Jessica Varghese.
Can you see my screen?
We will in a minute. There you go. You're now live.
Wonderful. Good day. I'm thankful for this opportunity to meet with you. My name is Jessica Varghese. I am an assistant professor of nursing and director of the RN to BS program at New York Institute of Technology. In today's presentation, I hope to share with you some key insights on this topic, professional identity in nursing. We assume people understand the term professionalism, regardless of what profession we're talking about. I expect professionalism from my healthcare providers. However, this term is often used very loosely, as my definition of professionalism may look different than your definition. This initiative guides us in nursing to move from the term professionalism to professional identity. My goal today is to introduce to you some key goalposts to help you understand and develop your professional identity, to really understand what it means to think, act, and feel like a professional nurse. This transition builds on knowledge from developmental psychology that identity formation helps individuals to truly understand what nursing is and how they can build and guide the development of their professional identity. To give you some background, there were 50 nurse leaders that came together to discuss this issue and develop work over the course of the last 3 years. The real purpose of it was to become more aware of professional identity, what it means, and how to use it. Here is the professional identity in nursing defined: a sense of oneself and in relationship with others that is influenced by characteristics, norms, and values of the nursing discipline, resulting in an individual thinking, acting, and feeling like a nurse. In our society, our identity makes such a difference. So it's important that as part of an individual's identity, this professional identity is clarified. So definitions are fine, but how can we really understand professional identity in nursing? Well, we've identified 4 key signposts for professional identity in nursing. And I think sometimes understanding these simple short terms are a great way to explain an idea. So the first one that we have is values and ethics. So values and ethics are really what it sounds like, a core set of values and principles that guide conduct. The next one that we have is knowledge, which is the analysis and application of information derived from nursing and other disciplines, its experiences, critical reflection, and scientific discovery. Leadership is, of course, a real key foundation. It's the ability to inspire yourself and others to transform a shared vision into reality. And the last one is professional comportment, a nurse's professional behavior that is demonstrated through words, actions, and presence. So how about this as a bumper sticker? This statement is evidence-based, by the way. Nurses must be smart to pass the NCLEX exam, wouldn't you agree? Nurses are trusted, as evidenced by Gallup poll year after year, and nurses are leaders in healthcare, as evidenced by everything we've seen exemplified in this past year with the pandemic. So really, it's better language for the important work we do. So how can we use it? I think one important thing is we have to support using this definition and the 4 domains as a mechanism to recognize excellence in nursing practice, in education, in regulation. What if we had and used these words to accurately describe really excellent nursing? It would be a big help. These 4 domains and the science that is growing to support them can also be used to coach nursing employees and students. Then to the public, there would be words to explain nursing to legislators and public officials. Overall, using professional identity in nursing language and knowledge well could be helpful in reforming and transforming the nursing discipline. As you see here, a great deal of change is taking place in healthcare. Even in the regulations of education and preparation, we're seeing this term of professional identity being incorporated into the AACN Essentials of Baccalaureate Education. Our regulatory bodies are starting to see that this is something very important that needs to be part of both a nursing student's education as well as a practicing nurse's understanding. All this sounds great. If you'd like to hear more and be part of this initiative, I urge you to look at these websites. A special shout out and recognition to Nelda Godfrey, who is really the architect of this initiative. There's a great deal of research and dissemination taking place. So really, please take a moment when you get a chance to hear more about what this initiative is doing and how it is changing nursing. In this last slide, really, we are at a place in history where we as professionals have to elevate nursing to the level that we should be at. And I hope that you have learned from this presentation, and I hope that you become part of this initiative, and I am open to answering any questions that you may have. Thank you.
Thank you. Thank you for that wonderful presentation and professionalism. We are now ready to move into our question and discussion from our speakers.
Hi, everybody. This is Elysia McMyers. I'm just going to ask again if anyone has any questions. Please feel free to put them in the chat. But I do have a question for Dr. Varghese. Excellent presentation on professional identity. And I think it's really important for new nurses when they're coming out to know what their identity is, or at least to learn what their identity is. So the question is for you is, how has healthcare or nursing leadership supported professional identity to better brand nurses?
That is a great question. So I think compared to other professions, nursing is a very young profession. I feel like medicine and law have really incorporated these pieces into their curriculums so well. So I think nursing is starting to get there. I think nurse leaders and hospital leaders are understanding that if nurses don't really have this foundation of what it means to think and feel and act like a nurse, you're starting to see, not only starting, but things are starting to become more evident, like incivility and bullying and, and unsafe or an unhealthy workplaces. All these are outcomes of that lack of professional identity. So we want to move away from professionalism because, it means different things to different people. But having that identity, I'm a nurse. This is something very important. This is a part of who I am, but I'm also a part of a profession that requires certain things. So I think hospital leaders are starting to understand that and investing in education, investing in creating a climate that fosters individual development. It's slow, but it's getting there. And I believe a lot of that change really happens from the nurses that are at the bedside, the frontline staff who are saying, listen, this is not okay, and we want it to be different, and here's what we need.
Thank you. Thank you for that insightful response. And we now have a question for Dr. Mary Joy Dia. What have you seen in utilizing technology to address the psychosocial and mental well-being? Any insights on how nurses are adopting apps?
Yeah, that's a very interesting question because obviously a lot of apps are out there, and I think the one thing that stands out in my mind is the one that was recently developed by Charlene Clayton and the team who won the last year's challenge, right, hosted by Johnson & Johnson, because it was really like an app made by nurses for nurses, and it sort of like addresses the whole continuum of care from a nursing perspective. perspective. In terms of the adaptability of it, I think there's a long way to go in terms of trying to incorporate that as part of their daily practice. I know within our own organization here, there is a resilience training program, and it's just helpful to open up your email at the start of your day and see this encouraging comments in terms of steps on how to be kind today. Because these are things that we don't really give a lot of thought, but inculcating this and really making this as an intentional practice really makes your day a little bit better to bear, especially if you have a long day ahead. So those are like some of the things that I have seen. The other piece is also those YouTube videos in terms of the mindfulness exercise. I know that there are studies about it, but I think the studies really show that the more that you practice over time, the more that you are more listening to your peers, you're more forgiving, so to speak, you're more into healing. So I think it's beneficial for us to adapt it slowly or quickly.
That's great. Thank you so much for answering that so wonderfully and clearly. Our next question, Dr. Varghese, are you ready?
Let's go for it.
So why is this topic now relevant? Why now?
So I think for better or for worse, nursing is in the limelight. I think people are looking at nurses and seeing the work that they do. Now, the term hero or not hero can be debated, but nursing is a profession that is more than just being at the bedside, right? So I think a great deal needs to take place for us to elevate our profession, and that can only happen if we can unify and all use the same language, right? I feel like nursing, there's always so much division about, you know, entry into practice and, you know, a bachelor's degree nurse is better than an you know, there's so much conflict related to that. And I feel like part of the reason that as a profession, we don't progress is because we can't unify. Now, these 4 domains, there's a lot of liberty in how you teach that and how you incorporate that, right? What we're trying to say is let's at least all together come and say, okay, here are the 4 guideposts. And then from there, you can sort of, you know, define leadership and expand on these and implement them in a way that makes the most sense for your department, your hospital, your college. But it has to happen now, because the truth of the matter is, if we as nurses don't define ourselves, other people are going to continue defining us, right? If we don't take that ownership and say, this is who I am, and this is who we as a body believe we are as a profession, other people are going to continue to say, oh, they just do what the doctor tells them, or they just change bedpans. Nursing's, and the other part, just to add to that, is the shortage that's going to take place within our profession is profound. And if we don't get more nurses to become nursing faculty, number one, because we need people to teach, and get students to see nursing as a viable option. And you know what? There's a lot you can do in nursing. I think in the future, I mean, it's going to be really hard to staff hospitals or community centers with nurses if we don't unify on this piece.
Thank you very much. Wow. I want to take another moment to thank our first 2 speakers, Dr. Varghese and Dr. Mary Joy Dia. That was very insightful, and I'm sure you have inspired many of our attendees. But right now, I want to take a moment to hand it over to our second moderator, Dr. Olga Kagan.
Thank you, Vaninma. I appreciate that. Thank you very much. It was very, very interesting. And thank you, Dr. Varghese and Dr. Dia. It's interesting, as you were talking, I actually thought about the Nurse Hack for Health that's coming up this weekend. And somebody mentioned that we had a high school person registered for the event, and it really warmed my heart, because I said, you know, we really need more people from that high school level to know about nurses and to work with nurses and to go into the profession. So, and as I was listening to you, I said to myself, it's really good to know that we have that new pipeline, and I hope we cultivate that at the high school level up. So without further ado, I do want to introduce our next panel of speakers who are also amazing. Katherine Crookston from NowPow and Kathleen Mcgraw from Microsoft. And I'll let them introduce themselves, and we'll start with Katherine Crookston, if you don't mind. The floor is yours.
Absolutely. Thanks so much, Olga. So a little bit about me, because you're going to get to hear from me after you hear from Kathleen's introduction. I think I'm the only one here who is not a doctor, if you will, but I am a nurse. And so as a nurse who actually got my baccalaureate at Purdue Nursing, still stay involved there, I'm still such an advocate of nursing. And I think about splitting my professional career has really been between the bedside and administratively in the acute settings. And then the other half of my professional career has been in health IT. So HIMSS is a natural place for me for health IT. And I love the fact, Jessica, as you said, the idea of nursing. There's so many avenues that we can really explore as nurses. So exciting to be here. I actually went from being acute care nursing administratively to health IT. Worked in the world of patient engagement when that was a novel concept back in 2005. And then in leading the sales team, both there and at Wolters Kluwer. And I did see, Jessica, you started out with the Wolters Kluwer slide there as well. My team really was really evangelizing not only patient engagement, but also the idea of clinical decision support tools that I know so many of us as nurses use every day. I only wear my nursing hat now clinically to do vaccinations, like I know Kathleen, my colleague, also is doing. And, we're happy to be able to roll up our sleeves and not only get vaccinated ourselves, but help others get vaccinated. Today, you're going to get to hear from me talking a little bit about a total different concept of care, really integrating community care into healthcare to improve outcomes. So I'm going to go ahead and tee it over to Kathleen to introduce herself. And then I know Olga will come back to me to actually speak a little bit more about community care.
Great. Thanks, Catherine. Thanks, Olga. I'm Kathleen Mcgraw. I'm Chief Nursing Information Officer for Microsoft. I really appreciate you giving me the time to speak today. I'm going to talk about artificial intelligence and clinical decision support to support nurses. I've written a couple articles on clinical decision support and artificial intelligence to support nurses and some essentials and the differences between AI and CDS. I get that question a lot in my role. My background is I am a trauma critical care nurse. I have my master's in nursing informatics, and I really went that route because as a clinician, in order to get when I was at the bedside, I had to do commands 3.2.1 for hematology and 3.2.2 for chemistries. And I wanted to know why I couldn't see it together. And I was told some engineers in the basement had designed the system. And I said, and they never asked the clinicians on the floor what they wanted. And I said, I want to see them together, right? So I think the sweet spot for nursing informaticists is that we can really bridge that gap between the clinicians and the engineering, the developers, which I think is really the value that I bring to my organization and to the folks that I work with. And I just want to say happy Nurses Week and Nurses Month. I'm really excited that we're doing this during this month. I think nurses should be celebrated all the time, but I'm glad that we actually have an opportunity to do that. So I'll hand it back to Olga.
All right, thank you so much. I appreciate that. It's interesting because I was saying the same thing, especially with since the start of the pandemic. We've had people reach out to nurses, and I've been in that shoe where I had to, consult with startup companies and just, there's such a need for that nursing input because the systems have to work for the nurses. And so happy to be able to contribute in that way as well. So thank you for sharing this. I'll go back to Catherine if you'd like to share your slides, and we'll get going with the presentation, and then we'll reserve questions to the end.
Sounds great. Thanks so much, Olga. And as I mentioned, I'm really excited to be here with all of my nursing colleagues today. So while our overall topic is high tech, high touch, you can see in the next 15 minutes, I'll be talking about technology and touch as it relates to integrating community care to improve health equity and health outcomes. Today, I'll share with you a little bit about the variety of different healthcare settings where nurses can really leverage technology and data to reduce the negative impact of social determinants of health factors. So those factors of where we live, work, play, and how they really impact our health. And then also how to support whole person care. Further, I'll talk a little bit about the strength of both having a platform and people to really create this community care model. You can really see the learning objectives right here. We'll go through how you can e-prescribe community care within a variety of care settings, developing that strong program intervention, and I should say workflow, because that's going to make that standard of care. And then because it is HIMSS, I want to talk about the data, the available data and the identified needs to personalize these referrals and what that data could mean if we want to measure the impact. Next. So why even think about this type of model of care? Now, you see I'm from NowPow, so some of these really will reflect that in the fact that I've got a nice statement there from our founder and chief innovation officer. There are other companies that are doing similar work as us. This is more about that model of care and why are we even thinking about this? Because frankly, in nursing school, I never thought about the kinds of referrals that I would make to those social and human services that are in the community. So those community connections as being vital. But I think there is a stark reality that you can see right here. And her statement that she said in a Forbes article just a few months ago was around, if our goal is to eliminate health disparities, we have to turn a serious attention to understanding and providing people with these high quality connections to vital health promoting resources in our community. Now, I'm going to be the first to say, as an ER nurse, I might have sent somebody out with that vial that they needed a medication, but I didn't ask them if they had a refrigerator to put it in. So when we think about the disparities here, the realities of maybe some of the basic needs not even being met, those Maslow's basic needs, and you look at the lifespan and the difference in 10 miles in Lincoln Park, frankly, where my home is, and Washington Park, where our company's hub is, there's a 12-year lifespan difference. So with that reality, and if we advance to the next, what some of you as nurses might remember in advance that there was a grant, a CMMI grant released by CMS. And I really remember all these grantees that received that. There were like 3,000 applicants, but what was exciting about it is Dr. Lindau started thinking about the idea of e-prescribing care. So e-prescribing the care as easily as you can e-prescribe medication. So each one of us as nurses understand how easily you can e-prescribe medication, how labs are ordered, but e-prescribing community, that was a really novel concept. In 3 years' time, in 33 clinical sites, and here's where I think is important for each one of us on here, everything needs to be integrated into the workflow, so connected into the workflow in a way that they would generate 350,000 of these e-prescriptions. E-prescribing community care had a third party evaluate, and it met these value-based goals. So those value-based goals, every one of the organizations you're working with that thinks about value-based, looks at reducing readmissions, reducing unwarranted ED, and that's wonderful. Now, if we go to the next slide, though, we're going to think about how does that really impact if we want to make this broad? So bringing things out of a lab and actually making them reality means we have to really think hard about how we're going to put a model of care like this in place. And the little figure that you see, the little person on the left of the screen is probably pretty familiar now to everybody who's thinking about the idea of SDOH factors and the impact on health. And as you can see right here, social, environmental, and individual behavior factors are more important and take up more of that percentage of really than genetics and healthcare itself on someone's health and well-being. So that might be known, but how do we apply a community care model to a full population? How do we make sure that we keep the well, the low risk, reduce the rising risk, and then focus some of both the people and technology on the high risk to really advance that? And do it in a way that we can all shift, as we keep hearing about, shifting to that value-based goal. So if we advance this, we have to think about the idea of really doing this for a full population. Now, each one of us that have been nurses, think about the different care settings. So when we think about that population health pyramid, the care settings that we might think of immediately are the ones that Kathleen and I worked in. So I was a cardiac nurse. I worked in high risk areas all the time, but yet there's also lower risk areas. So from both the acute, the ED, the post-acute, we think about ambulatory. And I want to be real with everybody on here. Nursing is more than any of these acute care settings, and we know that. And in the roles that I've been seeing a lot of nurses that we're working with that are in public health, that are in education. So those that are within the schools, whether that's in the university or the grade schools, those in justice that are doing medical care there, and those that are working in the employer, trying to work on the employee health, as well as the payers and their care management. We also know that nurses are one member of a care team, of a broad member of a care team. That broad team is physicians, social workers, pharmacists, nutritionists. And now if we think of a community care model, there's going to be more people around that table. So when you think of this model, you're even thinking about those guidance counselors, teachers, peer support specialists. Another team member you've heard a lot about, community health workers. So there's a variety of different care members that are really part of that broader care team, and really working together as all equal stakeholders is going to be incredibly important for this model. If we go to the next slide, what you will see is the concept is really around whole person care, meaning I want to take care of not only the basic needs, I want to take care of the needs that you might have, those wraparound service needs that someone might need. And then when we think about really affecting a whole community, so it is the entire population that you're focused on. So if we go to the next slide, then we got to think about the 4 different elements to really do this. 4 elements to put in place. 1, every referral has to be personalized. It has to be accessible to me. I have to be eligible for it. The last 2 speakers talked about the nurse as being this trusted advisor. We don't want to break that trust or erode that trust. We want to enhance the trust. But for each one of you as nurses, it's going to be incredibly important for this to be efficient right through your workflow. So we'll talk a little bit about that. If I go to the lower left, it should be scalable. You as nurses and every one of those team members I talked about, you need to focus your efforts on the rising risk and the high risk oftentimes, which means let's make scalable solutions so people can self-serve. People are pretty good at self-serving, right? We all do that every day in our real-time lives. So using the applications and apps and being able to self-serve is a great way to scale. And yet we need the data from all of these tools to be able to make sure that we can measure the impact. So now that we've talked about the 4 elements, let's talk next about the actual strategy around that. Strategy means that we have to really have strong programs and design around those. Intervention designs. Who is the population you're going to focus on? What is the objective and the trigger? Who's going to actually deliver this kind of intervention, and what kind of care setting are we talking about? So each one of these is going to determine, if we think about this, having purpose for you as care professionals to actually use this. If it's not purposeful, you're not going to use it probably. And then it doesn't become standard of care. And then you're not going to gather that actionable data afterward. So I think an example I would say, Children's Minnesota, who actually put something like this in place. They knew for sure they wanted to screen, understand food insecurity, and based on that, we're able to then procure those food resources and then have the data to be able to show that they went from 20% to 83%. Now, to me, that's meaningful. It's meaningful to keep that moving forward. Next, you'll see that we also have to think about like the ease of use. And in the ease of use, it's all about 5 easy steps to make this actually happen. If you want to advance to slide 1, I think we'll see that you think about 5 easy steps. It's about identifying, matching, then being able to share this out. And then again, back to the idea of data, generated data, to be able to understand the outcomes at an individual and aggregate level. So let's look at the next slide, because there I think what you will find is the identify piece from the perspective of thinking of data to really drive the entire model. The data here is data you already have at hand. Oftentimes you know a lot about a person. So using demographic data, the information that you might know about Kathy Crookston, my gender, the language, information that is right at hand within your EMR or whatever that data source system is. That's wonderful. Using health condition data, ICD-10, Z codes, bringing that in as well as screening data. So think of that as data you already know and data I can gather from the person. And also, if you are using different analytics, and as Kathleen is going to talk about some of these, AI and predictive analytics, how do you pull that in to also make that ideal match and automate the delivery? On the next slide, you'll see we're talking about it must be seamless for each one of you. So if you are a case manager who's listening in today, you're going to do comprehensive care. You need to know longitudinally what's happening. I might screen someone, be able to send a referral, know that the connection was made to a community-based organization and close the loop on that care. But if I am somebody who is simply screening across an entire health system, as some of our clients are doing, that's a wonderful way to have just activity specific. And it must be set up in a way that you're going to easily access and be able to use it. Of course, if I am that ED nurse again, maybe I'm occasionally making sure that I can source, find, and share a referral. Or as an analyst, I'm viewing the information and looking at some of that reporting. Let's take a look on the next slide at really what does that can look like. Now, just looking at within your own source system, you want to make sure that this is embedded into your workflow. We talked about it has to be a seamless access. Guided workflows. If it's not a guided workflow, and I can tell you even doing vaccine clinics that having the workflow matters. For ease, because you're doing this quickly, you want to do it efficiently, you want to spend your time talking with the patients or the people you are serving. And so it has to be easy, but it also needs to in real time document everything you're doing. That documentation and that data that you're gathering will actually give you the information you need to measure the impact. From a data flow, on the next slide, you'll see the actual data flow. For me, a picture is always easier to understand. How does that data flow? The people data that I said flowing into a platform, screening data. And this is meaningful. Again, no matter what kind of solution you're choosing, you want to make it easy for each one of you to be able to use this. And then, of course, sending back the information right within the chart. So if I'm looking in Kathy Crookston's chart, I know exactly what has occurred. And that raw data, let's look at that on the next slide. It is about the data to guide decisions. It's so important for you to be able to understand number of people that you might have screened or referred, the type of service and the close rate and success of that. And I think on the next slide, Sebastian, if you want to go ahead and advance, you'll see really just pictorials to be able to understand not only the data around referrals that are made, but the process outcomes and the performance of your network. Remember I mentioned those community-based organizations as equal stakeholders? Super important that they too understand what is the performance of having a community care model. Now, on the next slide that you will see, the guiding principles would be something that looks pretty familiar. The triple aim goals that IHI put out are around improving outcomes that reduce costs and improving the experience. I'm going to add one more and make it a quadruple aim. And it is one you're probably familiar with. It is around that care team well-being for each one of you. How do we make sure that you are going to have this right within your workflow, that is bringing joy to your work and a better experience that you are having with each one of the patients and the people that you serve? My last slide here is reviewing the objectives. And I'm going to close out, though, by not reviewing the objectives, but more giving a challenge. And actually, it's a challenge that I think Jessica mentioned as well. I want each of you that are listening to think about how do we support education of a care model like this? Not only for where your current work environment is, but really thinking about not only the education of that, but even at a nursing school level. In doing a HIMSS nursing article with a couple of colleagues, I really did the research to recognize that not often is this really taught in the nursing schools or the medical schools yet. is still relatively in its infancy. So become involved. As somebody who might want to be doing user design or evaluation, we talk about that a lot in our groups around the idea of any of these new technologies and care models of getting nurses really involved. And last, as I close it out and thank each one of you, my final slide is just, again, making sure that we would all say, how do we make sure that we close this health equity gap? And I think the idea of integrating community care into healthcare is a really novel and wonderful concept. So it'll be exciting to kind of measure what the impact could be. And with that, Olga, I give it over to you for our second speaker and look forward to any questions anyone might have.
All right, thank you, Catherine. Thank you so much. I think I'm back. Okay. So thank you very much. A lot of things really resonated, and I think it's a direct tie to our previous presenters in terms of, you know, really involving those stakeholders and making it easier for nurses with the workflow and just that, you know, ease of ability to function. And I think that, you know, certainly helps with the burnout and just in general the stress level that nurses experience. So I really see a direct, you know, connection here. So thank you so much, Catherine. And without further ado, I'd like to introduce Kathleen Mcgraw, and she'll talk about artificial intelligence and clinical decision support for nurses and also for the delivery of patient care. So Kathleen, please.
Thanks, Olga, very much. Thanks, Catherine. I love that you said utilize data to guide decisions. So I'm going to talk, kind of piggyback onto that. I'm going to talk about artificial intelligence and clinical decision support for nurses to deliver of patient care. So I do have the objectives as noted. I'm going to just go a little bit quick because I have quite a few slides, quite a bit of content that I want to cover. It's difficult to cover AI and clinical decision support in 15 minutes. So please ask questions or follow up with me after. I'm happy to discuss. I'm going to start with our CEO for Microsoft, Satya Nadella, talking about artificial intelligence, representing one of technology's most important priorities, and healthcare is perhaps AI's most urgent application. According to research, 4 trillion gigabytes of healthcare data is generated annually, and this is projected to double every 2 years. So we think we have a lot of data now. Just imagine that doubling. So AI is not new. We've been in a journey for decades to augment human capabilities in one of these 3 areas. So if we think about the first calculators, which could do better than humans, even with mechanical options like the Grant calculator in 1877, electronics has really opened a new frontier for AI. Natural experiences like voter, a machine able to mimic human voice, or first attempts on reasoning machines. And then computers, bringing graphical user interfaces and voice recognition or self-driving cars as early as 1994. But really, why are we talking about this now? So there's really, you know, you've noticed artificial intelligence is kind of the hottest topic to learn and one of the most important things that's impacting healthcare today. So really, why is it so important now? It's really 3 things. We have more data, we have more compute, and there's a lot of innovation around algorithms, tools, and frameworks. So for the more data, we know that we're able to capture and store more data about how our machines perform, about our patients, about our providers. I can store the data and I can process that. So the more data I have, the more accurate a model that I'll be able to go and build. The second thing that I mentioned was more compute. Because of the cloud, we have this more compute power that's available with a lot of different options about computing. One of the amazing things about the cloud is that you can rapidly go and deploy a large number of machines or a small number of machines. And this changes the economics of deploying the workloads. So you can spin them up and pay for them for just a couple of hours and then bring them back down. And finally, there's a ton of innovation in algorithms, tools, and frameworks over the past 5 years. And this makes it even more personalized for services and experiences as far as them getting powered by insights that can be gained through machine learning. So I'm going to take just, you know, a little bit of a step back, and I want to discuss about the DIKW framework, which everyone should be familiar with. So it's data, information, knowledge, and wisdom, the framework that's known as the DIKW framework. I've been in informatics so long that it was the DIK framework. There was no W. That's been added since I've been out of school. But in nursing practice specifically, many of the AI models utilize a specific framework to make decisions that affect care delivery. So the framework known as the DIKW framework, it helps nurse informaticists determine how data, information, and knowledge are used in the decision-making process. And the framework really has specific definitions that help shape each of these concepts. So you can kind of go through the table and see data, it's little or no meaning in isolation from other factors. Information is data plus meaning. Knowledge is derived by discovering patterns and relationships between different types of information. And then wisdom really brings understanding, internalization of knowledge, patterns, and relationships. And that's what we're really going to focus on when we get into the AI. But in many cases, AI models are paired with clinical decision support applications that can really help our practitioners advance from knowledge to wisdom. And that involves exercising judgment. So that's an important point to make. When using AI for clinical purposes, the DIKW framework can be used to categorize clinical decision support tools, and this ultimately allows practitioners to strategically evaluate relationships between AI and CDS. I used to get a lot of questions when I talked, especially with nurse leaders, Kathleen, what's the difference between clinical decision support and artificial intelligence? They are not the same thing, so I need to be really clear about that. Clinical decision support provides clinicians with computer-generated clinical knowledge and patient-related information that is intelligently filtered and presented at appropriate times to enhance patient care. And on the other hand, artificial intelligence may be thought as the fuel that powers more intelligent clinical decision support. So I'm going to talk about that AI once I get through the DIKW framework, but I did think it was important to kind of like set it up. So the framework is particularly relevant when designing CDS tools to advance nursing practice to top of licensure to improve nurse decision making. And the DIKW framework can be used to categorize the CDS tools that you're using today, including those that are driven by AI. So the framework's pyramidal, which implies that data is profuse and wisdom is rare. And as previously talked about, data have little to no meaning in isolation. Information is data plus meaning, and knowledge is derived by discovering patterns and relationships between types of information. And wisdom is really ultimately understanding and internalization of knowledge, patterns, and relationships. So the DIKW framework isn't just a way to understand how information can be processed. It's also a means by which providers can strategically evaluate the relationship between AI and CDS. So the pyramid illustrates the hierarchical nature of the AI and CDS applications. So really, it's data capture, data processing to meet information needs. Clinical knowledge is based on rules to guide decision making, and then exposed analytics in the form of wisdom to augment nurse decision making. So from a clinical user perspective, the bottom three levels of this application usually aren't visible. The user really only sees the top, and the fourth level in the form of an alert or a dashboard or a risk score or an application or some other interface. However, when we're investigating AI and CDS applications, it's really important and essential to understand how all the levels are developed and validated. And we're doing this more and more as nurses. So I'm going to just briefly talk a little bit about AI and kind of go through the rest of the material that I have. And then when we wrap up, we'll be able to learn a little bit more with our questions. So artificial intelligence is an area of computer science that emphasizes the creation of machines that work and react like humans. This means systems that have the ability to depict or mimic human brain function, including learning, speech, recognition and generation, problem solving, vision, and knowledge generation. So there's multiple ways that we can amplify human ingenuity with intelligent technology. We can do things such as learning, which is the ability of technology to learn to become smarter over time. And this is what really separates AI from just intelligent automation. One of the reasons why AI is so promising is because it changes this paradigm in how we've been writing software code. So instead of programming every if, then, except condition, essentially telling a computer engine what to do, AI tells the computer engine to learn and figure it out on its own. I'm going to expand on that in a minute. Reasoning allows AI technologies to extract critical information from large sets of structured and unstructured data to perform clustering analysis and use statistical inferencing in a way that starts to approach human cognition. And cognition allows AI technologies to form conclusions with imperfect data. Interacting allows AI technologies to use computer vision to see, conversational AI to communicate, and computational linguistics to read again, getting closer to human level cognition. So when I talk about machine learning, This is the type of AI that learns and improves without human intervention as it processes data to predict the things that we care about. So machine learning is really considered a very narrow part of AI, and machine learning needs to look at many examples when learning to solve the task. So expanding on the primary concepts of AI, where machines show capabilities that are usually associated with human capabilities, you can see how learning over time, interpreting data, and reasoning with data works. Additionally, machine learning creates algorithms varying from simple linear functions to extremely complex ones, like an artificial neural network. That's a whole nother topic I won't have time to cover today. Instead of manually creating an algorithm, we train it with lots of pairs of inputs and outputs, and the result is called a model. The model can be applied to new inputs to get those outputs. So the model is just a function, just like any other function. The difference is that we're trying to do is learn the parameters of that function from all of the data that we have. And that's what machine learning is. It takes a variety of different algorithms and techniques to take all of that data and learn the parameters for that function. Now, how do we do that? Typically, we'd be using some type of different computer languages, such as Python or R, or frameworks like scikit-learn, and that's actually how data scientists build models. Of course, we need to help them because we need to let them know, what the data is, where we need to find it. So what does the model actually do? We can do all types of different types of modeling, but there's really 3 primary categories, and then there's others, but we'll just touch briefly on regression, classification, and clustering. So regression is one that we commonly remember, which is we've got a bunch of data. I want to fit a line or a curve to that data. And the way we do that is we look at all these data points. We do some math and we derive parameters, M and B, for instance, in this equation where we're trying to draw a line. And that's what machine learning is. It's going through and finding where are the right parameters. The second machine learning is classification, which is given an input. What class does it belong to? One really common example here is image classification. So when given the image, is it a dog, a cat, or a tiger? This requires me to have a lot of pictures of dogs, cats, and tigers. And then I do the math on that and create a function which can take any picture, including those I've never seen before, and make a prediction. Now, we don't have to just do classification on images. We can do this on classifications of patients. So keep that in mind. And then another type of work that a model will do is clustering, which is trying to understand and segment all of my customers and discover what are the different clusters of those customers. Similarly, search is a clustering problem, which is given a keyword or given an article. How do I find articles that are related to this topic? Or how do we teach a machine and go and do that? And so that's what it really takes to build a model. It's what a model does. It's how we can go and use it to do a regression or do a classification or do a clustering. But that's only part of the problem. You'll note every time I've talked about the model or talked about machine learning, I've talked about data. So there's no machine learning without data. It's a huge part of the machine learning problem is finding the right data, shaping it, cleaning it, preparing it, and then to go and build and train the model. And then you have to actually go and do something with that model. So these are the 3 stages of machine learning, which we find our data, we prep it, and then we build and train the model, and then we deploy. So when we refer to AI in the context of health, we typically mean machine learning, ML. The AI ML components are individual pieces in bigger health systems that combine big data, cloud computing, and emerging devices and user interfaces. And AI will enable organizations of all sizes to achieve better business results because we can maximize the 3 trends that I talked about earlier, which is massive data, massive compute power, and breakthrough algorithms. So I'm convinced that the quadruple aim is the single best path for technology to create a new value in the emerging value-based care model. So thanks, Catherine, for bringing that up. The quadruple aim is really our best definition of value in value-based care, and achieving the quadruple aim is really going to take what it takes to make the health and care personal, effective, and affordable. So we're driving towards digital transformation in the industry against the quadruple aim, because it's not just digitizing that exists today, but it's truly about transforming it. So some of these new paradigms, what they might look for, we're going to use real-time predictive analytics to shape outcomes. We'll be able to provide research on demand and connect all devices to all databases, and ultimately erase historical boundaries of data. So data is coming in, users want to get to it, and they want to get to it fast. So I'm just briefly going to talk about some of the ethical questions to consider, because we really do need to take this into consideration. So what's the plan for thoroughly stress testing AI for unintended biases? In the context of bias in artificial intelligence, a model needs to reflect socially responsible values. Developers of AI and healthcare teams need to identify and take steps to address bias and avoid introducing or exacerbating healthcare disparities when testing or deploying new AI tools in vulnerable populations. Are we effectively identifying and managing the ethical implications of technology? Can we explain how the AI makes the decisions moving data? We need transparency in the AI algorithm to be necessary to understand what went into it and why. And is there a clear breakdown of how the adoption of AI will adhere to the fundamental principles of managing AI in an ethical way? AI will produce results as good as the data available to do it. So what we need to do is we need to have more research on AI and ML fairness on existing models. This might include investments in interpretable models and causal models, and the AI should be agile enough to adapt to changes in clinical settings. For example, the same model shouldn't be applied across settings in which workflows and policies are different, such as acute versus intensive care settings. So here are a few questions that we can ask about potential AI and CDS tools using the DI-KW framework. So remember, it's around data, information, knowledge, and wisdom. And then there are a few tips for organizations and care teams to advance AI responsibly. We should demand non-discrimination. AI needs to reflect socially responsible values as noted in the ethical discussion. The data used to teach AI are biased based on what research is conducted, and the AI model should not discriminate against people based on age, gender, sexual orientation, race, or ethnicity. Developers of AI tools and healthcare teams need to identify and take steps to address bias and avoid introducing or exacerbating healthcare disparities when testing or deploying new AI tools on vulnerable populations. We need to protect the patient. Patient privacy is a key concern and affects how AI is developed and tested. Privacy reflects on the nature of a provider's relationship with their patients, and individual privacy must be protected at all times. We need to investigate the AI algorithm. Transparency in the AI algorithm is necessary to understand what went into it and why. Can the model be explained? Clinicians will seek insights into what AI is doing and won't accept a black box when it comes to patient safety, quality, and outcomes. And check the data. AI will only produce results as good as the data available to it. With a vast amount of data coming in from multiple disparate systems, it's critical that organizations have an effective data governance strategy in place to maximize the full potential of their information assets and the potential of AI. So when employees and clinicians hear AI, their minds typically jump to an image of a robot doing their jobs. And in the development of AI for use in clinical delivery or administrative tasks, having clinicians and staff input in how AI can best help them do their jobs can advance responsible use of AI. So remember, AI is tasks, not jobs. Helping employees, clinicians do their jobs, not replace their jobs. Eliminating burdensome tasks and producing better outcomes. It's really about automation of tasks, a better work life for employees and clinicians, and creating better experiences for patients. So I would like to invite everyone to register and take a course, AI in Healthcare, Leading Through the Change. It was done through the American Hospital Association and Microsoft. It's our responsibility to ensure there is an avenue for learning for our healthcare providers and clinicians. So we actually worked with the AHA to develop this course on AI in healthcare. It's Leading Through Change. The course is free, CEUs are received, and we're really making this offer in order to take our responsibility to educate on AI very seriously. So thank you, Olga and team, for the opportunity to talk today.
Thank you, Kathleen. I appreciate this presentation very much because you truly incredible job and really differentiating between the clinical decision support and AI. I think that's something that people often don't get. And personally, I enjoyed the breakdown of the data information knowledge wisdom model because that's something we drill in the nursing graduate program for our nurse informaticists. So that's a topic we discussed extensively. So thank you for that. And I know in the interest of time, I'd like to jump right to the questions that we have. Alicia, I don't know if you have any questions, if you don't mind just chiming in here.
Sure.
Thank you.
Thank you, Kathleen. Also, thank you, Catherine. What a great presentation for AI and the communities that we serve. So one of the questions that we have is, both of you kind of touched on coordination of care. How do you think AI and coordination of care really interacts with each other in terms of, I know you spoke about rural communities, but also what about your urban communities?
So I can start that, Alizia. I think that artificial intelligence is a great opportunity for us to look at our patient populations, cross our patient populations, help us coordinate the care of those patient populations. And I consider patients whether they're rural or urban, right? So I'm thinking of all that are within our community of care. So if you think about, say, a group of patients that's at high risk, you could utilize, if you have the data, you could leverage the predictive modeling, utilizing artificial intelligence, essentially to predict those patients that may be at greater risk, say for kidney disease, chronic kidney disease. There are certain factors, and we know what they are. It's built on the modeling of having the data in the system, building the model, and then could you proactively do outreach to them or somehow get them care to where they need to be getting their care? And then I'll hand it over to Catherine because she probably has some other thoughts there too.
Yeah, it's kind of interesting looking at it from two vantage points. So when we think about a community care model, it is about mapping all the resources and whether that's going to be in an urban, a suburban, or a rural. But you bring up a really good point, Alicia. In a very, very rural area, there are going to be just as many reasons to really connect somebody to some of those community-based organizations. Yet it could be that there would be actually a food desert in certain places. Or it could be that behavioral health, that there are not as many community behavioral health actual infrastructure assets. But for that, and I think there was a little bit of talk about telehealth. So how do you actually have virtual care? We've all been doing it. We're doing it today. How do you incorporate virtual care as an actual asset that can be incorporated into care? So I think when we think about technology and leveraging some of these, Kathleen brings up a good point. I think Mary Joy actually talked a little bit about telehealth in her discussion as well today. So I think there's really applications to be able to kind of incorporate that into this coordination of care.
Thank you both for your responses. So it's great that you both bring up technology. What do you both consider is the minimum technology required for the whole person care and whole communities for providers and the clients or patients?
So from a whole person care, as far as the technology you need to put that in place, is that correct, Alicia? Yeah, minimal. So we're all connected today. And when I think about the kind of connections that you would do using something like that we do at NowPow or others, any of the healthcare organizations already have a data infrastructure. They're using an EMR. This can be embedded directly within their source system. And really, they're going to be able to use it directly from that. From a person point of view, you can text, email, print, or put on an after visit summary directly. And when you think about that, I would prefer somebody text me that resource. And someone else might prefer the modality of emailing the resource. But making that connection directly to the community-based organization, as long as they have an internet line, they're going to be able to accept and manage a referral. So you keep all stakeholders. And when I say that, it's somebody making the referral, receiving the referral, and the person getting the referral themselves all on the same page, which is ideal for what you think about it as everybody's on FaceTime together, and you're actually making that connection together so that now they really can feel that whole person care. You've given them the right resources to improve their health and well-being.
So Alicia, I think Catherine makes a really good point. I do think we need to meet patients where they are, how they choose to be, engaged. But I also think we have to be aware of which patients have the availability of technology or which do not. I have worked with some organizations where they actually got grant money and they gave patients iPhones for a limited time so they could do their telehealth because they just didn't have accessibility to that. And I know, I live in Baltimore, Maryland, and we have a big problem with technology in the Baltimore City area and this huge cost that people just can't afford. They're trying to get their kids educated, remotely right now. So their thought is not on how am I going to do virtual health. So I think we just really need to be conscious of that, do that good assessment and really know the whole person, right? How do we take care of that whole being? Some of them, many have phones. I'm not saying that they don't, but there is, I think, opportunity here to learn more about these communities and then kind of meet them where they are.
Yeah, one thing I would add on that, and I know we're going to be running out of time, the good news that we're probably all seeing out of Washington is the kind of funding that is coming from broadband, that is coming, I've been on school boards before, that is really coming for education. Kathleen brings up a great point. So some of this is really going to be deployed, I think, across a lot of vulnerable communities, which is terrific for everything that we're doing here from a healthcare perspective and from an education perspective both.
Thank you so much, Catherine. I appreciate this. I know we're running short on time, so what I'd like to do is turn to all four of you for some closing thoughts. And just from your personal professional background, if you're going to just, if you didn't touch on that, please do, and just give us maybe within a minute or so response on the closing thoughts and where you think we should be headed in terms of patient care. And I know we're very complex beings, but we also have technology that's driving the future. So we have to coexist and we have to make best of it. So I would appreciate if all of you will take a minute and give us some closing remarks. Thank you. Why don't we start with Mary Joy Dia? Would you like to lead us?
Sure. So thank you so much. I really appreciate this robust discussion. And I know that it's really a holistic approach of taking care of ourselves, taking care of our patients, and taking care of our community. And that's really what's important from a Future of Nursing campaign, because we will still continue to address all of this social determinants of health, looking towards health equity, but at the same time, really look at how resilient we can as a person, as an individual, as a community.
So just
thank you very much. Jessica, yes, please jump in. Thank you.
I think the key part of what all the speakers today, I think what ties us together is that as nurses, there's so much opportunity for us to incorporate technology into our everyday practice, but also to improve healthcare. And I think that role can't be emphasized enough. So whether it's, going towards additional education or advocating for changes in practice at where you work, or collaborating with specialty organizations such as HIMSS, there really is a lot of opportunity to learn and grow in our field and ultimately to impact healthcare in our country. So, I push for professional identity because I think it's important for us to know who we are and for our society to kind of see the impact of the work that we do and the outcomes that we as nurses are responsible for.
I'll keep it brief since I already introduced myself and I feel like I'm saying ditto to everything that my colleagues here, other speakers are actually saying, but there are both challenges in healthcare and we all recognize them every day, and yet so many opportunities. So I love the idea of some of these novel care models. I agree with Jessica. I think there's real opportunity here for us to make a big difference. And I think care has moved in so many directions within the community, so far beyond the acute care settings. And there's just so many avenues that nurses can go, just thinking about all the speakers that are here today and our own professional journeys. So I will tee it up to you, Kathleen, to conclude, and then over to Olga.
Thanks, Catherine. Thank you. So I think that the theme of our summit says it all. I think as nurses, we can do high tech and we can do high touch. And I have great hope for the future of nursing. And thank you all for all you do every day.
Thank you, Kathleen. Thank you to all the presenters. It's been a pleasure to hear you speak today, and we hope that tomorrow during the replay, others will tune in and get to hear those amazing presentations, very informative. And finally, I'd like to introduce Anthony Ferrante, who is our New York HIMSS chapter president-elect and chief technology strategist at AMF Innovation Consulting, LLC, for final thoughts and closing remarks. Thank you.
Say that the New York chapter is very well represented by the nurses, and happy Nurses Week, super job. Couldn't ask for anything better. Everybody did a great job, and the nurses all, a task that's really, being able to hit it on both ends. It's fantastic. This event will be up tomorrow at, so you can hear the replay. We'll have it set up for tomorrow at 12 noon and then again at 5 p.m. So if anybody, pass the word. If any of your cohorts hadn't had the opportunity to jump on for tonight's meeting, it'll be replayed so you can listen to it again. 26th of this month, we will have another virtual event. And as you can see, it's up on the screen. Medicine needs modern technology. And we've got some great presenters instead of being once again. Pass the word also. It's plenty of great opportunities for education, as well as also being able to coordinate and collaborate with your peers. Producer, some Roy in the background to keep everything moving in a smooth and efficient manner. Thank you again. And again, thank you to all of our nurses for the great job that they do on a daily basis to protect the health of all of our folks. Thank you. Have a great night, everybody.